Big Money Bound TV, RRT Posse YouTube. If you're new to the channel, please like, subscribe, and turn on post notifications. I release scheduled videos every Monday, 12 o'clock a.m. Eastern Time, but I also release some unscheduled videos throughout the week. Now, if you're returning, hey, welcome back. I appreciate all of the support. Thank you. Today's video, a subscriber asked me a question and said, do I have any advice? What would I do? I said, you know what I'm gonna do? I'm gonna put myself in that subscriber's shoes. If I was you, what would I do? With what you asked me now, what would I do? All right, now you asked. Hey, keep watching, dog. Just keep watching. What we represent, man?
Big Money Bound.
Say, let her know, man.
Big Money Bound.
Alright, so the subscriber asked me, subscriber Rena J. Hey, thanks for responding. I watched the video and it didn't really touch what I'm looking for. Hey, I'm glad you came back so I can touch on whatever you're looking for. Thanks for coming back, because Big Money Bound TV, I can help. Trust me. So basically for me, I work at a level 2 trauma hospital. We are currently short-staffed and they kind of just threw me in working the floors, and I'm still waiting to finish my orientation. Between rapid responses on my patients, cold blues, PRN calls, and my scheduled treatments, by the end of the shift, I am overwhelmed. My scheduled meds are given late due to my critical patients taking priority, and I just don't feel satisfied at the end of my shift. Before I keep reading, let me start right here and let me insert my thoughts right here. Thug just told us, man, between rapid responses, cold blues, PRN calls. For you that may not know, PRN call is like when somebody is they have a written order for a breathing treatment to be given as needed. So it's not scheduled, but it's as needed. So if they ask the nurse for it, the nurse will call you and say this patient wants a treatment, you gotta give it. So that's another treatment added onto your list. That's a PRN call. And my scheduled treatments. By the end of my shift, I am overwhelmed. My scheduled treatments are given late due to my critical patients taking priority. Okay, so now the scheduled meds are given late. So you did those all 4 things, and you still gave all your meds, even though they was late. And then you said, I'm so overwhelmed, and I just don't feel satisfied at the end of my shift. You don't feel satisfied. You did all of that, and you don't feel satisfied? Damn, what more you gotta do? You gotta save the whole world? Like, you managed to do all of this and still get your scheduled treatments, but they was just late? And you don't feel satisfied? Like, drop down in the comments, am I wrong? Am I kind of tripping? Shorty managed to get all of that stuff done, all of that, and not feel satisfied? After doing all of that? On top of all of that? Hey, Rena J, you kind of got to give yourself like more credit. You should feel like a superhero, like Wonder Woman, after you did all of that. You completed all of that. It shouldn't be no, I just don't feel. You should feel like triumphant, like I got all that done. Where's my money? Where my raise at? Bro, you did more than enough to feel beyond satisfied, in my opinion, though. So let's keep reading. We gonna keep reading. Some of the nurses are new grads or incompetent, so they do depend on me a lot with when their patients is deteriorating. Let me stop you real quick. Hold on. You said some of them are new grads, so they may be a little unfamiliar. They're trying to figure everything out, or they incompetent. So that's your 2 options of nurses you're dealing with. Some people that kind of fresh out of school and don't know, and some of them are just incompetent. Like, come on, you tell me, don't nobody know what they doing? Thank you for commenting. If I was you, I'm gonna answer, if I was you. But like, I know somebody knows something now. Somebody gotta know something what they doing. Like, drop down in the comments. They new grads or they incompetent. Like, that's my 2 options. That's what I'm working with, dog. Like, all RT Posse, I love y'all, dog. Y'all know how to make, bro. Y'all know how to make my day, dog. I'm telling you, dog. And y'all say I'm the funny one. Others say they new grads or they incompetent. That's my two options. That's what I'm working with. All right, so let's just keep reading. They either new grads or incompetent, so they do depend on me a lot when their patient is deteriorating. Or I go in for a treatment and I find my patient is hypoxic with an SpO2 of 74%. That's extremely, extremely, extremely low. 74%, the patient will be blue. Sometimes the finger may be a little too cold, or not saying it may not be hypoxic, but 74, that's really, really like critical low. Like that's cold blue itself. So I guess I just would like some advice on how to get through something like that. All right. This is like a great point right here. I go in for a treatment and find my patient is hypoxic with SpO2 of 74. So I guess I would like some advice. Okay. If you go in there, you find your patient is 74% on O2. First thing we're going to do is we're going to increase the oxygen. So once we increase the oxygen and the patient's SATs return to normal, you use this as a teaching moment for whichever nurse has this patient. Let's say the patient is on 3 liters throughout the day. You go in there, the SATs have dropped. You gotta now turn it up to 5 liters. So you notify the nurse, hey man, a woman, man, it don't matter, I'm just saying, hey man is just a general term. Hey man, I had a patient here that you're covering. The patient's SATs dropped down into 70s, 80%. I had to turn them up 2 liters. So if you can just pass a note on to the next person coming on that throughout the day, the patient can withstand a good saturation on 3%, but when it comes nighttime and the patient falls asleep, they need a little bit more FiO2 to keep that saturation up. So now, you letting them know that throughout the nighttime, the patient's SATs drop. So you pass on this information and y'all like a cohesive like teamwork and group. So now this may help that new grad understand that next time she comes into a patient room and patient SATs are low, patient is desatting, she's not going to, oh my God. Oh no, well last time that lady gave me a call and she said, just turn it up. So that's what I did and the SATs went back to normal. And also, let's say you have a patient that's a mouth breather and they're on nasal cannula throughout the day. So when it comes nighttime and they're breathing throughout their mouth now that they're asleep, the O2 is going through the nose and it's not helping saturate the patient. So they're hypoxic. You then put on a masked O2. A venti mask, a non-rebreather mask, partial rebreather mask, a simple mask, anything that's going to cover the nose and the mouth. So now the patient is getting oxygen through the lower airway that they're breathing into, through their mouth. You then inform the nurse again, hey, throughout the day, this patient did well on a nasal cannula, but when the patient sleeps, they begin to mouth breathe. So they need a face mask oxygen device at nighttime. Now, you're not only teaching that at nighttime we got to change the O2 devices or the FiO2 percentage, you're also showing that you're a competent respiratory therapist. And now you letting that nurse know that when I'm here, I'm going to be checking up on my patients and I'm going to do everything right for my patients, which is then going to make that nurse, when working with you, check up on the patients just as much to make sure that the patient is not desatting at nighttime. So that's a great teaching moment when you find somebody with a low SpO2 and hypoxic. That's a great teaching moment. You also said that they do depend on me a lot when their patient is deteriorating. That's the best thing that I want to hear as a respiratory therapist. That the nurse and staff is dependent on me a lot. That means job security. Big money bound TV. Big money bound. That means I'm going to be here. I'm going to keep getting paid as long as I do what I'm supposed to do because they need me. They dependent on me. Now, I don't want it to be where, well, yeah, my patient is crashing. No, we don't need the RT. I can handle this. I can fix this, no problem. Go give me a non-rebreather mask. I'll call the doc, have him put in for ABG. We'll see what's going on. Whoa, that's great. then they're gonna start thinking, well, we don't really need this person. I'm not really feeling needed. No. Anytime you feel like they really depend on you, they really need you, that is great. Try not to let that change. I ain't saying you gotta do every little thing, but being dependent upon is great. So that's a good problem. Being dependent on you, hey, for whatever reason, that's good. They there, you there. If you there, Fetty there. That's just what I'm saying. I'm being honest, bro. And then you continue by saying, the hospital I work at has respiratory therapist driven protocol. So I can put orders in, start therapies, and put orders in, etc. The doctor also depends on me to assess and treat patients according to the protocol. The docs usually only get involved if I can't stabilize the patient, and I do have to call rapid response because I know my patient needs to be transferred to the ICU for more close monitoring. All right, is going to get intubated, etc. That is the only time the doc actually stops by. Other than that, anything respiratory related, it all falls on me. I would love to hear your advice. Hey, dog, I would love to work where you at. Anything respiratory related, it's all up to me. I go and assess the patient, see who need breathing treatments. Which also means if I'm putting in these orders for these respiratory therapy treatments, I can adjust these orders as well. Which I wish I had the power to do when working in the state of Florida or at my facility. Because, drop down in the comments, how many of you guys have seen a patient that came into the hospital with something unrespiratory related, with no history of respiratory issues, getting breathing treatments Q4 and you gotta give them? And you telling me you can go in and take that out or never put that in? I'd love it, man. You don't know how good you got it. So if I was in your shoes, this is what I'd do. First things first, I'm doing an initial check on every patient I got. Everybody I got, I'm gonna see who critical. First things first. Who is my critical patients? Who really needs these breathing treatments? Patient been getting treatments for the last 2 months. Patient doing good, 99% on room at. Yeah, we can kind of knock this off. Do you take treatments at home? No, I never took treatments before in my life. Do you have any history of breathing problems? I had asthma when I was like 3 or 4 years old, but I haven't used an inhaler since I was 5 and never had any breathing problems since then. I'm going to discontinue that. It's time to knock this off. Or I may just change it to PRN if you call, but I doubt if you will because you are 99% room air. Then, anybody that's on Q4 that can go to Q2, which, my bad, we can go to Q6, which is 2 treatments per shift. Or anybody that's getting treatments throughout the day and I don't want to do treatments at night, so I'm gonna sleep at night, don't worry about it. I'm changing their orders to daytime only. Anybody who on Q4 treatments and don't need them that often, I'm changing them to Q6. Anybody who don't really need a treatment is not finna get it. You got a lot of power in your head. Like hey dog, you got it good. So if I was you, first round I'm checking everybody. You don't need it, you're not getting it. You really need it, you gonna get it. You got Q4 and you just need Q6 or while awake, that's what I'm changing your treatment to. You've been getting treatments for the last 6 months and you don't need them no more, I'm changing you to PRN. So I'm reducing my workload. I'm lightening this stuff up to make it manageable while still doing my job. And then on top of that, when it comes to assessing the patients, they call me for a patient. If it's something that you can handle, all right, this patient just need a breathing treatment and I'm gonna do an ABT just to be sure that everything is okay with the patient. I'm gonna inform the doctor of what I did and how the patient is now doing. I'm gonna make these orders. The doctor ain't gotta come. I'm gonna tell him what I did, so now he's aware of what's going on with his patient. Because he may wanna, no, don't give him a treatment. You never know. I'm gonna let him know for that. And if it comes a time where it's like, I gotta call a rapid response because the patient is crashed and I can't, what I'm doing isn't helping, we gotta be intubated. Hey doc, I need you, dog. It's time to show up. Yeah, I know you've been enjoying your break, enjoying your Ritz crackers and your Cheez-Its and all that. Hey, it's time to make the big bucks now. It's time to show us why you getting paid. You feel me? It's time for somebody to be intubated. And that's how I would handle it. Like, I wish I had that. I got people putting in orders left and right for nothing. I mean, bro, I'm telling you, you don't know how good you got that power until that power is taken from you. Now just imagine You ain't the one putting in treatments no more. Every patient on this floor got treatments who don't need them. And you ain't got the power to go in there and take it away. That's what I'm dealing with. That's what I work at. And I'm still happy though. Because, hey, I'm employed. It could be worse. Respiratory therapy got me here. So, hey, if I was what you was at, you know what? Hey, drop them comments. What are you at so I can apply? The state don't matter. Where's you at? Please. Hey, man, that's all I got for you. Drop down in the comments. Let me know how you feel. If I was you, that's what I'd do. Now, if you got a question, Randy, if you was me, what would you do? Hey, drop the comments, and I got you. Trust me, I got you.